Non-sheath proximal retrograde access as alternative technique in complex femoropopliteal total occlusions. In this chapter we describe tips and tricks of no-sheath retrograde puncture technique of the tibial arteries in their proximal portion, immediately below the knee, as well as distal SFA or distal popliteal puncture, for the management of complex occlusions. Material is essential to perform the technique. Without it, we can fall into failure and discouragement, even more so if we are on a learning curve. Micropuncture set with 7 cm long 21 gauge needle. A 15 cm long is necessary for cases where the artery is deeper. 300 cm 018 guide wire, preferably with short floppy and good support to progress the devices. 2.6 French CXI microcatheter with a straight tip. The last one is a 4 French, 10 cm, sheath with mini guidewire type. Although we are not in favor of using introducer to minimize trauma to the artery, these may be necessary in case of failure in re-entry or rendezvous, or due to difficulty in entering the vessel at the moment of the puncture. The latter occurs in overweight patients, deep punctures of SFA and in highly calcified arteries. Retrograde access step by step. First 1. Position. We always place the patient in the supine position. This allows access to the distal SFA and the first portion of the popliteal artery below the adductor canal by flexing 15 degrees the leg. We can also access the third portion of the popliteal artery or tibio-peroneal trunk in cases that the disease extends to distal popliteal. In turn, it will also allow us access to any distal trunk in its proximal portion. We avoid prone decubitus due to the discomfort of working with a double access. Here we can see the position of the leg depending on the puncture point we choose. Second step, choice of the access vessel. When we treat complex occlusions of the femoropopliteal sector, we prefer to perform a puncture as close as possible to the occlusion but in a healthy artery. We need a margin of 7 to 10 cm over the lesion to be able to work. This gives us advantages such as larger vessel diameter, so the puncture will be easier, and more thrust and more pushability and support compared to transpedal access. In case of puncture of a proximal distal artery, we prefer to choose the one with the poorest runoff to preserve the best distal exit in case of complications at the puncture site. Third step, puncture. It is important to choose a needle length according to the depth. Puncture is done at 45 degrees angle. The technique can be performed guided by ultrasound, or guided by fluoroscopy. We prefer the latter for convenience, since we often use arterial calcification as a guide, or in other cases we do a guided contrast puncture. The needle should go parallel to the artery. Using maximum magnification, if you perform the puncture under fluoroscopy control, will facilitate the access. It is important to have the patient fully under heparin before performing the retrograde access. Here we can see SFA punction with a 30-45 degrees contralateral oblique projection in line up with the artery. We can rotate to contralateral oblique view at 90 degrees to assess needle distance from the vessel. In these two videos we can see a contrast guided puncture of the peroneal artery, and in the other a guided calcium puncture of the tibial-peroneal trunk. Four-step, retrograde recanalization. After the arterial puncture, we use a 018 support guidewire with a short floppy tip. This allows us to advance the materials. A small cut in the skin is done to allow the entry of the microcatheter. This point is very important. Then we switch to a recanalization guidewire. Our preference is V18. After the successful re-entry in the proximal lumen, the guidewire was introduced in an antegrade angulated 4 to 5 French hydrophilic catheter. When re-entry was not achieved using the retrograde access, the guidewire was introduced inside the catheter in the subintimal space. Sometimes it is necessary to perform an angioplasty of the occluded vessel from the anterograde approach to achieve rendezvous. If it is not possible to perform the trap in this way, we can use a loop from the anterograde approach to catch the guidewire from the retrograde puncture. The importance of using a 300 cm guide wire becomes apparent once we have the guide wire caught. We can perform a through and through that will allow us, by tightening the guide wire at both ends, a better advancement of the devices from the anterograde approach, very useful in the case of severe calcified chronic occlusions. In these videos we can see, in the first one, a retrograde recanalization. In the second we see a failed attempt at anterograde recanalization due to the large calcification, while after a retrograde approach we achieve, relatively easy, recanalization through this access. In these last two videos we can see the rendezvous technique, hunting the guide to the retrograde approach through a catheter from the anterograde access, saving the use of a loop. Five-step hemostasis. First one was achieved using a blood pressure cuff inflated 10 to 20 mm of mercury above the systolic arterial pressure of the patient, during 10 minutes. Once this time has passed, we will check that there is no bleeding or any complications in the retrograde access. If necessary, we can perform angioplasty if there is any residual defect. The use of the cuff allows us to continue working while we perform hemostasis, but on the other hand we lose the advantages of through and through. We can also perform hemostasis using a size-to-size balloon angioplasty at nominal pressure. This will be done once the case is finished and after placing an alternative guide wire from the antegrade approach before removing the retrograde guide wire, to secure the vessel, parallel guide wires. 10 minutes of inflation is usually enough to achieve correct hemostasis. The fact of not using a sheath means that complications are minimal, since we minimize the trauma to the artery from the retrograde approach. Some authors have described the use of percutaneous closure devices after the removal of the retrograde sheath, although we do not recommend them routinely. 6-step medical treatment and follow-up. All patients were under single antiplatelet treatment with aspirin 100 mg or 75 mg of clopidogrel prior to the intervention. After the intervention, patient goes with continuous dual antiplatelet treatment during 1 year. In the patients under anticoagulation treatment regime, aspirin 100 mg was associated before and after the endovascular procedure. To verify distal vessel patency and rule out local complications, controls of the retrograde puncture site were made by duplex ultrasound at the end of the intervention and at 1 month. After, the standard monitoring protocol of the center was followed. There are 3 possible complications resulting from the procedure: arterial spasm, bleeding, or vessel occlusion. In the event of spasm, we will proceed to instill intra-arterial nitroglycerin. We recommend 200 to 300 micrograms prophylactic in the case of poorly calcified arteries. With the described technique, avoiding the use of sheath, the risk of bleeding is minimal, and if it exists, we will prolong the hemostasis time with the techniques described above. It is essential to ensure that there is none bleeding before completing the procedure. In our series we have no cases of thrombosis or arterial occlusion, but if there is a defect in the distal puncture site, we will proceed to perform a prolonged angioplasty for 2 to 3 minutes. If the problem persists, we can cover the area with a stent, that depending on the vessel, will be self-expanding or balloon expandable in case of minimal and very localized defects at the origin of the distal trunks, not at the origin of the anterior tibial, to avoid compression of the interosseous membrane. These are my recommendations. Time matters. Change your strategy after 10 minutes if you are unable to re-entry from the antegrade approach. Check the necessary material before starting the procedure. Larger vessel diameter, easier puncture. Use maximum magnification if performing the technique under fluoroscopy. Have all the material ready when you are going to perform the retrograde puncture to avoid losing access. The closer you get to the occlusion, the more pushability you will have. Always leave a distance of 7 to 10 centimeters. Do not advance the guide wire from retrograde beyond the common femoral artery. In cases of superficial femoral artery occlusions from the origin, re-entry is more complicated at this level. Always look for rendezvous in the superficial femoral artery. Try to maintain the through and through until the end of the procedure, especially if the anterograde access is contralateral or brachial. Anticoagulate the patient at full dose once retrograde approach is performed. All patients must be on antiplatelet therapy before the procedure. In case of obese patients or those with a lot of calcification, access through the SFA may be more complex, especially entering the vessel. Use a more distal puncture or a 4 French 10 cm introducer in case that the microcatheter does not advance into the vessel. Skin cut is very important. Try to avoid the use of a retrograde sheath to minimize trauma. Let's see some clinical cases. Case 1. In this first patient, we can see a segmental SFA occlusion, with extreme calcification. 3 runoff vessels are patent, also very calcified, and anterior tibial seems to be the best. After the failed attempt by antegrade approach, where we can see an arteriovenous fistula secondary to the angioplasty performed in an attempt to advance the devices, we proceeded to retrograde puncture of the tibio-peroneal trunk fluoroscopy guided. After verification, we performed retrograde recanalization successfully. Hunting is carried out using the rendezvous technique by advancing a catheter from the antegrade access. You can see the final result after the implantation of a stent, with the disappearance of the fistula. Case 2. In this second case we observed an occlusion of the superficial femoral artery, practically from its beginning with repermeabilization after the adductor canal. Here we can see how we were unable to re-enter from the anterograde approach, creating a subintimal dissection and with a great difficulty to advance the devices. Given this scenario, we switched to a retrograde approach. We performed a puncture of the anterior tibial artery, the only patent distal trunk. We can see the mild spasm that was resolved with the injection of nitroglycerin, and we began retrograde recanalization. In this case the re-entry was at the level of the common femoral, although we are more in favor of doing the rendezvous technique in the superficial femoral, in this case was not possible. The hunt was inside the contralateral sheath and in turn inside the catheter that we had inside, achieving a through and through that gave us support to advance the devices and finish the case. This is the final result after angioplasty of the entire occlusion and implanting multiple stents. In conclusion, non-sheath proximal arteries retrograde approach is a safe technique that allows the treatment of complex chronic total occlusions of the femoropopliteal arteries. It avoids the inconveniences of the popliteal approach, allowing the use of a double access. Proximal distal vessels puncture facilitates to treat patients whose atherosclerotic disease is extended to distal SFA and the popliteal artery and make easier the puncture in obese patients. It also permits greater support and pushability regarding more distal punctures, thus obtaining greater technical success. The performance of the technique with a 2.6 FR entry profile avoids the complications observed in other retrograde techniques described. Thank you for your attention.